All right, so the title of today's talk here is Respiratory Season, the RSV outbreak. And the reason for that is that every year we do have a respiratory season where we usually have increases in respiratory cases through the fall and winter months for a couple of different reasons. And, for those that have been watching the news, we certainly know that RSV this year is something that is, really kind of reminiscent of early COVID, where we're getting reports of all of these cases, overrun hospitals, that type of stuff, right? So that's what kind of brought us to put this together. So our objectives for the day is we're going to talk a little bit about how viruses actually work, kind of the physiology of what viruses actually do in us to make us sick. We're going to talk some numbers, some epidemiology of what is the actual big deal of RSV this particular season in comparison to past years. We'll talk some pathophysiology, and along with that, the assessment and management, both pre-hospital and in-hospital management of patients with suspected RSV. And then we'll kind of close it out today with techniques for stopping the spread. And a lot of this does, like as I kind of mentioned, does have a lot of kind of crossover from early COVID, where we were talking about things like masking and distancing and that type of stuff. We're not there yet. It doesn't mean that we're not going to be. I don't know. I can't predict the future. But a lot of the things of, stopping the spread of, covering your cough and not going to work if you're sick, there is a lot of crossover there for obvious reasons. 1 sec here. So again, a couple people just came in. If you, for your credit, just go ahead and follow that link in the chat and sign in here. So we're going to start today with a couple of polls to kind of get some a little bit of a knowledge check here to see kind of where we are entering in here. So the polls should kind of pop up on your screen in a sec here. When I launch them, go ahead and click what you feel is the best answer here. So first question here is, who is at risk for contracting RSV? Check all that apply. The young, which is kids, which we're going to define as kids under roughly 5 years old. The old, adults over 65 years old. The middle, so most of us on the call here, 18 to 65, or our really little guys, our premature infants born less than 35 weeks. And this is at high risk. Now, granted, everyone can get it. So who's at the highest risk here? And you can check multiples here too. So check all that apply. I put these polls in so I can sip my coffee. Right. Looks like we're slowing down on responses. All right, let me share this with the group here. So it looks like the winner is our young ones. And yeah, that's absolutely true. Kids under 5 are the big population here with, really the lower or the littler the kid gets, the more at risk they are. The ones that are at risk for kind of the highest mortality, so like getting real sick and death are actually our premature ones for reasons we'll discuss later. And one thing that kind of gets overlooked here is that our adults over 65 are also at risk. I know there's a lot of similarity in physiology between our little guys and our old guys, simply because we have decrease in muscle tone, respiratory muscle tone, decrease in compensation, that type of stuff. So adults over 65, especially those with things like COPD or other respiratory kind of ailments and diagnoses, are also at risk. Today we're not going to be talking about that group of folks. We're going to be focusing on the pediatric population because that's, I think what people are the most concerned about here. But what we do know is that RSV, for kind of the folks in the middle here, right, there are 18 to 65 demographic. People will still contract RSV here, but they typically won't have severe symptoms as long as they're in good health. So what we're really concerned about here is the little guys, like the real small ones, and that's what we're going to kind of focus on for today. Second knowledge check before we move on here is what condition does RSV most often cause in patients? And this is going to be specific to our little guys. Is RSV causing bronchitis, bronchiolitis, pneumonia, or asthma? we did this presentation a couple of nights ago. I think it was Wednesday night, comparing your answers to see who's the smarter group. Right, a couple answers trickling in here towards the end. All right. Let's see here, by a small margin, we have bronchiolitis, speeding out bronchitis, and pneumonia. And this is somewhat of a trick question because RSV can cause bronchitis, bronchiolitis, and pneumonia. No one went for the asthma kind of outlier because viruses don't cause asthma. Like that's just not something that happens. So the one that we're most concerned about in RSV season is the bronchiolitis, right? We're really good at kind of treating pneumonia and bronchitis, but bronchiolitis is almost exclusively seen in RSV cases. And we'll kind of talk about that physiology a little bit later here. So really good, off to a good start here. So let's move forward. Let me get rid of the poll. Go. So why are we here? I guess that's the question of the morning, is how did we get into this kind of situation? And anybody who reads a newspaper, watches the news, has a news app on their phone is being inundated with headlines like this, that RSV on the rise, hospitals full, doctors warning people to take precautions. And these are just headlines that I pulled when I was updating this on, I think, Monday or Tuesday of this week. These were just headlines from that day from various news outlets. So, it's definitely in the news. It's definitely around, and for a good reason. And we'll look at some of the numbers in a sec here. But we know that our children's hospitals specifically, so CCMC up in Hartford, and then Yale Children's down in New Haven, are completely overrun. Very reminiscent, like I said before, of kind of early COVID, but on the pediatric side of things. So we kind of got to think like, well, what's different about this season than past seasons that's put us in this kind of position? And to do that, we kind of use a little bit of a case presentation of the life and times of little Bobby. And little Bobby, this is based off of a real case that happened within Middlesex County in the past couple of months. And little Bobby was born sometime in July of 2020. And if we think back to July of 2020, it was certainly a different place where we were kind of in early COVID. Little Bobby's born, he's healthy, he's happy, 10 fingers, 10 toes, COVID-free, but his family can't meet him. Because if you remember back in that summer, that first summer of COVID, everything was shut down, right? There was visiting restrictions for hospitals, mask mandate, social distancing. Perhaps you remember the one-way aisles in the grocery stores, things like that. Like everything was kind of crazy. And certainly nobody's getting into a newborn nursery to see a little kid during that time period. So if we fast forward about 6 months till January of 2021, this is when RSV typically spikes, right? We had at least a very kind of predictable pattern of RSV spiking sometime December, January of every year, right? And it was something that was reliable. It was something that we could, set our watches to, that every, mid-December, late December, January, the children's hospitals get these spikes in RSV. But this year, it doesn't happen. And the reason it doesn't happen is because RSV is spread in a very similar way as COVID is, right? So if everyone's masked, everyone's distanced, and everyone's scrubbing everything, and no one's seeing each other, no viruses are going to spread. And in fact, if we look at the epidemiology maps of all of the respiratory illnesses, RSV, flu, even common cold, all of those things dropped to nearly nothing for that entire winter. So Bobby, this would have been probably the winter that Bobby would have gotten RSV if there wasn't the shutdown, right? So then we fast forward another year. Bobby's 18 months. We're at where we should have had RSV spike number 2. This season goes, very, very similarly to the last, where we have a little bit more of a spike of RSV, but still not the numbers that we were used to seeing. So Bobby's still healthy and happy. He's met his family. Everybody's very careful. And what they're careful about is we don't want to give little Bobby COVID. And as a result, we're also not giving him the other illnesses. So everyone's kind of cognizant about hand washing. Everyone's wearing a mask around little Bobby, really taking extra precaution. And again, with good reason. Fast forward till October of this year, Bobby's a little bit over 2 years old. He ends up, mask mandates and social distancing are relaxed. The world's back open again. Germs are flowing. Bobby never developed antibodies to some of the common respiratory illnesses, gets very sick, and ends up intubated, right? And that's kind of what we're seeing here, is that RSV is a very common respiratory virus that usually spreads in the fall and winter months, but this year it's showing up early, right? It's showing up earlier and earlier, and it's spiking higher and higher because all of the kids that would have gotten typically RSV in the past 2 years didn't. So we're kind of playing catch up with those kids, right? And if we take 3 years of what should have been RSV cases and we plop them all in the same, couple month period, we get the spikes that we're seeing right now. And this has led to stresses specifically on the pediatric specialty centers, but all that kind of trickles downhill, right? So if the children's hospitals are full, the outlying EDs like Middlesex can't transfer the pediatric cases to the children's hospital. It's only a matter of time before that trickles down to kind of everywhere, right? And that's exactly what we're kind of seeing here. Now, the thing that we're going to mention here, but we're not going to go into in great detail, is we're kind of expecting to see spikes of flu this year for the same reason. And so when we take these things, and I was reading an article about this, we take the flu, right? And then we take the RSV spikes, and then we have COVID still around as kind of our new normal background. We really have kind of 3 epidemics going on kind of all at the same time. And one journalist was trying to coin the phrase either tridemic or tripledemic. I see the point for sure, because we're definitely in a pretty severe respiratory season here. Now we have these 3 things, but we also have to remember is that somewhere in the background here, we still have that common cold. And the reason I bring that up is that all these illnesses really kind of present similarly, at least in the early kind of days of symptoms, right? So we know that the common symptoms are all the usual things: sore throat and a little bit of a cough, maybe some fatigue, all of that stuff. And when our little guys present with that type of thing, we just don't know which one of these viruses we're dealing with. But what we do know is that all of these things on the screen here are all viral, right? So since they are all viral, it kind of makes sense to dip into a little bit of virology here and understand how viruses kind of work. And I think that the image on the screen here is something that, image of a virus is something that we have certainly grown accustomed to in the past couple of years of COVID here. Understand, though, that this is just one kind of type of a virus. It's a spherical virus, and that different shapes of viruses do exist. The reason that this one's on the screen is that this is what, what COVID is, what RSV looks like, and influenza looks like. They're all kind of this spherical shape. So starting on the inside and moving out, that orangish stuff on the inside, that's all genetic material. And that genetic material can be either DNA or RNA, it depends on the virus. But either way, it is the virus's genetic material. Moving outward, we have a protein coat and then an envelope, which give the virus some sort of structure and protect that genetic material somewhat. And then on the outer surface, we have those very, very now familiar spikes, which are nothing more than protein spikes. And what these spikes do is they attach to specific receptor sites on cells out in the body. If it weren't for the spikes, the virus couldn't connect to our cells and couldn't make us sick. We'll talk about why that's important in a sec here. Really, that's the way that the COVID vaccine works, is breaking down those spikes. So what ends up happening here is we have our virus, we have our cell, and as our virus connects into our cell, genetic material is transferred from the virus into the cell. And that's where everything kind of starts here. Now that genetic material, like we said, can be either DNA or RNA. Now, DNA viruses, we know that DNA viruses are going to inject the viral DNA into the cell. And as a result, that viral DNA takes over the cellular machinery to make RNA in the nucleus. So let's kind of explain that a little bit. Typically, normal physiology, with our cells just doing what our cells do every second of every day, the DNA contained within the nucleus of our cells creates something called RNA, or really more specifically, messenger RNA. And that messenger RNA goes out to something called our ribosomes within our cell. And our ribosomes are the thing that make all of the proteins that we need to live. So ribosomes make proteins for us, and those proteins are typically beneficial. But when the viral DNA kind of takes over that machinery, it starts to create this viral RNA, or this viral messenger RNA. That messenger RNA, that viral RNA, goes to the ribosomes, and instead of making proteins that are good for us, it starts to make viral proteins, and the virus starts to replicate and duplicate and copy itself. So as we copy this virus and more of it are being produced by the ribosomes, the cell gets injured, eventually breaks apart, and all of those newly formed viruses are released out into the environment, out into the body to go and infect other cells. Now, this is a very kind of predictable process. DNA goes in, messenger RNA is created. From that messenger RNA, new viruses or copies of the virus are released. And because it's a very predictable kind of system and a very simple system, there's a low chance of these DNA viruses to mutate. Now, RNA viruses are a little bit different. Instead of injecting DNA, RNA viruses are going to inject single strands of RNA and some enzymes into the cell, right? When the RNA and those enzymes go into the cell, they combine and they make viral DNA. So instead of injecting viral DNA directly, we're going to be injecting some RNA and kind of doing the reverse process. The process is actually called reverse transcription in order to make DNA from RNA. Now, from there, the process is the same. The DNA goes to the nucleus, we make viral RNA, RNA goes to the ribosomes, makes viral proteins, and we replicate that virus. So we add in another step here, right? We add in this RNA, we have to reconstitute in a way DNA, then that DNA makes messenger RNA, then we make the virus from that. And because we're adding an extra step, right, because we're adding that extra step, there's more things that can go wrong. And because of that, there's a higher chance of mutation. So that kind of makes sense here if we look, like, because we know that these RNA viruses are the ones that are particularly dangerous to here. You know, this is saying in genetics, if what doesn't kill you mutates and tries again. And that's exactly what we see here. So if we kind of look at the list here, DNA viruses, varicella, HPV, smallpox, Hep B are some examples here, all with vaccines against them and reliable vaccines against them and long-term vaccines against them. Why is that? Because their process, their physiology is straightforward and simple. And if we can predict what the enemy is going to do, we can attack the enemy very, very, very reliably. RNA viruses, on the other hand, are things like Ebola and COVID and the common cold, flu, HIV, and our friend RSV here, which is the reason we're here today. Now, it's really difficult to make viruses or to make vaccinations against these things because you make it against one strand of the virus and then it mutates and becomes a different thing. And we saw that with COVID, right? We had the initial COVID vaccines come out and everybody was happy and they got their two-step vaccine in most cases. And then we had to get boosted. And then we have this new one out that particularly looks at going after that Omicron variant. And that's just the reality of RNA viruses. They mutate, and as they mutate, we have to kind of change the way that we vaccinate against them. Flu shot, absolutely the same thing. Every year we have to get a new flu shot because every year there's new flus out there. We actually use Chinese data to figure out what is China seeing for their flu season, and we take that information and we say, this is what we're going to see in our flu season. And we take those viruses and we make vaccinations against them. So like when you go and you get your flu shot, what you're really getting is a shot against the top 2, 3, maybe 4 strands of the flu that are out there. Now, if you get infected with another strand of the flu, you're going to get sick. Right? It's as simple as that. And that's where we see like these vaccinations saying that they're 70% or 80% effective because they can't account for all of the different mutations. DNA vaccinations, on the other hand, really can. You know, you get a Hep B shot or your series of Hep B shots, and you may have to get a booster a decade from now. You know, smallpox, same thing. So next poll popping up here is who gets RSV? We find it here. Here we are. The question is what percentage of children contract RSV before their second birthday? We have 0 to 19%, 20 to 39%, 40 to 59, 60 to 79, and then 80 to 99%. Interesting results. A couple seconds here. We'll flip it around. Right. Looks like we have a two-way tie here between the 20 to 40% of the 60 to 80%, and both of those are actually wrong. So congratulations to the two of you who answered 80 to 99%. So let me pull the poll down and throw some numbers up here. 95% of all children contract RSV by age 2. That doesn't mean they're going to be hospitalized. It just means that they are contracting the virus. And that speaks to how contagious this thing really is. So again, by age 2, 95% or more of kids statistically are going to contract that virus and therefore make antibodies against it. Now, these numbers account for about, these are national numbers, account for about 2.1 million outpatient visits a year and 58,000 hospitalizations. And those numbers, understand that those numbers are not projected numbers from this year. This is based on kind of data from years past. We expect these numbers to be much higher this year. And if we kind of think about that, like higher than 2.1 million visits to outpatient centers, that's going to be things like urgent care, primary care, that type of stuff. That's a lot of sick kids, right? A lot of sick kids. And we have 100 to 300 deaths under the age of 5. And, you know, you look at that number, you're like 100 deaths in the entire nation. That doesn't seem like a whole lot, but it really is if we consider the fact that there's about 3,600 total deaths under the age of 5 nationally every year. You know, 100 to 300 of them are accounted for by RSV. Pretty high numbers for a virus. And again, that is old data from kind of pre-COVID, this year statistics. So some pretty impressive numbers, pretty big numbers, way bigger than I thought it was going to be when I started researching this stuff. So some data here. I'm going to try to break this down. I know these graphs can be a little bit confusing at times, but if we look at this, we have 3 years of data here. The purple kind of mountain looking data points here, those are pre-COVID numbers. And we see here that we have a very, very defined spike in like December, January, and then a gradual kind of falling off period through like, I don't know, March or so. And then we stopped tracking the data because RSV doesn't really come around again until the next year. Now, if we look at the blue down at the bottom, that is the first year of COVID. So that is the 2020 to 2021 season, right? So we see here, this is nothing happening for a long time. And then we start to see some cases pop up in the summer of 2021 here and there, but certainly nowhere near a typical spike. We're about half of a typical spike. Now, the way these graphs work is at the end of this blue line is the beginning of the green line. So we're going from September 2021 at the end of the blue line to October 2022 at the beginning of the green line. And that kind of spike continues a little bit, really plateaus here for a couple of months, then falls off where we usually spike, which is kind of unique. Not a whole lot's happening through February, March, April, May, June. And then in July, we start to climb a little bit. In August and September, we really start to climb. right? So then we take the same data and we overlay where we are right now. October of this year, we were up near where our usual spike is, and now we're well above where our typical spike is. Now, keep in mind, this is data as of, as of 11/3, so pretty recent, about a week old at this point. But that's where we are nationally, and what this is showing is we have 10 per 100,000 kids. And we're defining kids here as anybody under 18 years of age. There's anyone under 18 years of age is what we're looking at here. So 10 per 100,000, maybe 11 per 100,000, somewhere in that range. Now, if we take this and we overlay, we look at Connecticut numbers, right? So that was national data. This is Connecticut numbers. We know that this is, almost double what the national rates are. And that kind of makes sense because if you think about what Connecticut is, I mean, Connecticut, we think of ourselves as being, rural to some respect, especially, in parts of Middlesex County, out east, the Putnam area there. But that's certainly not rural in comparison to something, say, like Montana. I have some friends that have a farm in Montana where the nearest neighbor is a 30-minute drive. So from that perspective, where we're a little bit kind of close together, a little bit more densely populated than a lot of regions, the whole eastern seaboard's like that. We kind of makes sense that viruses would go person to person a little bit quicker here. But more importantly, what we see here is that, again, this is anybody under the age of 18 with a positive RSV diagnosis. We are at more than twice what a typical spike is. And again, the number is still on the rise. Now, if we take this same data, so remember the number here, 20 per 100,000, and we look at just kind of the little kids, this is 0 to 6 months, we are at 250 per 100,000 being diagnosed with RSV or being hospitalized for RSV in Connecticut. So this is 2.5 times the usual spike, and certainly the highest kind of at-risk population from a numbers perspective here. And that's where kind of the concern comes from, is because if you have somebody who is either intubated or requires aggressive care at that age range, 0 to 6 months, there are very few places in the state that can provide that sort of care. One of them being the Children's Hospital up in Hartford, and one of them being the pediatric center down at Yale. But your typical run-of-the-mill community hospital doesn't have the capabilities to treat those patients. COVID was a little bit different in that the community hospitals, they have respiratory therapy. Patients can be on ventilators at community hospitals, that type of stuff. I know that Middlesex had a bunch of events all through COVID, but the pediatric stuff is really a subspecialty there. So if we take this huge spike on an already limited resource, we end up with the situation we're in here. So CCMC here, most of these numbers come from CCMC, but I know that the same is true down at Yale Children's. CCMC, so just for kind of reference here, CCMC has a 35-bed emergency department. And they're seeing 30 RSV cases roughly coming through the ED per day. So that's, an entire ED's worth, almost an entire ED's worth of RSV cases coming through each day. And they have what are called boarders in the emergency department. And what boarders are patients who are admitted to the floor, but the floor is full. There's nowhere to put them, so they stay in the ED. And the boarders here are taking up, when I put this together, it was taking up half of the ED beds, but now it's probably even more than that, right? And I was on a call end of last week, I want to say, and they were saying that they have more boarders in the emergency department than they do in the PICU, in the pediatric ICU. So even if they were to discharge the entire pediatric ICU and admit the people from the ED, there would still be people in the ED waiting for beds. Now keep in mind, like this is not a Connecticut problem. This is a nationwide problem. And on the call I was on the other day, they were saying that they're getting the CCMC transport team is getting 15, 20, 30 requests from out of state to have patients transporting from, Rhode Island, Massachusetts, wherever, into Connecticut because there's no beds anywhere. So really kind of a big deal here. Now, like I said before, this is eventually going, it already has started trickling downstream, where if we have a critical RSV case at a community hospital somewhere in the state and the pediatric centers are full, those community hospitals are going to kind of have to come up with creative solutions to treat these kids. And, I know that both pediatric centers are offering kind of like over the phone consultation type of stuff with the physicians within the community hospitals for guidance on how to treat these kids. So really kind of a scary thing if we think about it. And probably the scariest thing is that we might not even be at the peak of this yet, right? The numbers are still on the rise. I was reading some data from a couple of weeks ago, and we were seeing roughly a 75% increase in cases from week to week through all of October. And if that trend continues, we can just kind of imagine what's going to happen here. So now that we know the data, we kind of know like what the current state of affairs, I guess, is. We have to ask ourselves, what is this thing? What is this thing anyways? So like we said, it's a virus, and it's transmitted very, very similarly than COVID, right? Where we breathe it in, nose, mouth, whatever, and that virus starts to make its way down the respiratory tract. And then a few days later ends up in the lungs, and we start to see symptoms. So from time of exposure to symptom onset, right? So if we define symptoms beginning as day 0, there we go. If we define symptom onset as day 0, right? Somewhere from 2 to 7 days before symptom onset is when the exposure began. So we call that like that 2 to 7 day period there. We call that the incubation period, where the virus is in the person, but symptoms haven't started yet. So the person doesn't know that they're infected, but when the symptoms develop, they certainly do. So the first symptoms to typically develop around that day 0, that symptom begin, is usually a runny nose, sneeze, right? Runny nose and sneezing. And it kind of makes sense, because if we think about this, the virus is entering into the upper airway structures, and it's infecting the upper airway structures first. So the upper airway structures are the first thing to kind of get a little bit angry, right? So we get that runny nose, we get that sneeze. Then about a day and a half later, the patient's going to develop a fever, right? And that kind of makes sense too. So we inhale a little bit of the virus, and it starts to infect the upper respiratory structures, and then it starts to replicate and duplicate, and more virus comes out, and our body kind of catches wind of this and goes, hey, we're infected with something. We better start the stove and make this kid a little bit hotter. So fever comes in about a day and a half later, just due to the amount of the virus that is replicated by this point. By day 2, the virus has moved kind of south in the respiratory tract far enough to start a cough. Then around day 3, the wheezes start. So it takes about 3 days to get from like those nasal passages, upper airway stuff, down to the lungs, and in the lungs, eventually resting. We're going to talk about in the bronchioles to cause bronchiolitis and wheezing. Now, the contagious period here is when the fever starts, up to about 8 days from symptom onset, right? So now, this doesn't mean that this is the only time this person is contagious. It just means that this is when they are the most contagious. So we can kind of think about this the easy way and say, if the symptoms are worse, they're more contagious. If the symptoms are less, they're not as contagious, but not completely not contagious, right? And this contagious period in some populations can go on for weeks. We just don't know. It depends on so many different factors. So our assumption has to be that if we have a patient that is symptomatic with RSV, they are contagious. So if we think about this, the virus is making its way down the lungs. If the virus settles kind of in the upper airway structures, it's going to cause bronchitis. If it settles down in the lower airway structures, it's going to cause bronchiolitis. And if it settles way down in the alveolar sac, it's going to cause pneumonia. So kind of important to understand here that it's the same viral infection in 3 different spots here. We call it 3 different things, but the physiology is really the same of that replication and all that stuff we talked about. So if we take these 3 conditions, bronchitis, we know larger airways, we're going to have a productive cough. It's going to be that chunky, green, nasty looking mucus that's going to be coughed up. bronchiolitis, we're down in the smaller airways. This is going to look very, very, very much so like asthma. There's going to be wheezing, there's going to be bronchoconstriction, there's going to be air trapping, there might be a dry cough, but it's very, very, very asthma-esque. Pneumonia, we're down in the alveolar sacs, like we said. There might be some wheezing, maybe not. And there might be a cough, maybe not, and that cough may be productive or not productive. So really kind of a variety of symptoms, because the further down you go in the respiratory tract, the more kind of unknowns we get there. Now, what we do know is that all of these three conditions, so we can call all of these three conditions kind of in conjunction, RSV as a whole, is going to cause a fever, it's going to cause shortness of breath, it's going to cause hypoxia, it's going to cause decreased PO intake, and it's going to cause fatigue. That just kind of makes sense. It's all of our usual kind of respiratory illness stuff here. Now, we're not going to talk too much about bronchitis today, because bronchitis is going to be kind of the more minor cases here, further up in the respiratory tree. We're not going to talk too much about pneumonia here, because it's really the bronchiolitis that is the big driving force kind of behind this RSV season. So if we said bronchiolitis was a lot like asthma, but they're kind of like reverses of each other. So in bronchiolitis, we get inflammation of the bronchiole, and with that inflammation, we get mucus production, we get a little bit of edema, and we get really kind of angry bronchioles. And because the angries are inflamed and angry and whatnot, they constrict. Right, so we have inflammation that causes bronchoconstriction, versus asthma, where the primary problem is bronchoconstriction, and then that bronchoconstriction causes inflammation a little bit later, right? So we kind of have reverse processes. In bronchiolitis, inflammation causes bronchoconstriction, therefore the solution is to fix the inflammation. So if we think about where the inflammation comes from, it comes from the viral infection. Versus asthma, we have bronchoconstriction as the problem that causes inflammation. The solution is to fix the bronchoconstriction. And if we fix the bronchoconstriction through things like inhalers or steroids or whatever else, problem solved, problem goes away. Without fixing in bronchiolitis, without fixing kind of that root cause, the problem kind of continues on here. So here's a little picture of our alveolar sac here. And if we kind of zoom in here at the bronchiole, right, our terminal bronchiole here, just before the alveolar sac, we know that we have this smooth muscle all along the bronchiole that is responsible for bronchoconstriction and bronchodilation. Muscle contracts, we get bronchoconstriction. Muscle relaxes, we get bronchodilation. So if we take this little area here and we blow it up, we can see that we have all of these pinkish looking epithelial cells. We have the red on here is representative of the smooth muscle, and then we have the yellowish kind of circles here or ovals here that are representative of what are called goblet cells. And goblet cells are the things that are responsible for producing mucus. So if we take that and we blow that up even more, we can see that we have a virus within one of our cells. So our RSV virus made its way through replication all the way kind of down to our bronchial cells, and our virus is now taken over or taken hostage the nucleus of this bronchial cells by injecting that genetic material into it. As the virus here starts to replicate, the cell breaks apart. And when you start to break apart cells down here, your body gets concerned and your body says, hey, we need to fight this thing. This is where the fever comes from and all the things we talked about. Now, one thing that happens is our goblet cells start to just dump tons and tons and tons of mucus. And mucus actually gives us the most immunity, the best immunity that we have against anything is all the mucus we have in our body. So if we think about that, the whole role of mucus is to trap that virus and let it go nowhere, right? It kind of holds it in place so that we can eventually cough it up and spit it out into a tissue or onto the sidewalk or, whatever else, right? So we have really good immunity from our mucus. So it kind of makes sense that one of the first things the body would do when it's trying to fight off a virus or a bacteria, whatever, is produce some mucus here. Now, in response to this, anytime we put something that shouldn't be in the bronchioles into the bronchioles, in this case, we are putting in some mucus, in some viral stuff, in some cellular debris here, our lungs or our bronchioles constrict. So we get constriction of the bronchioles through contraction of that smooth muscle. Now, the other thing that kind of happens here with cellular injury, right? We have our cellular injury, which is going to cause an inflammatory response like we talked about. And part of that inflammatory response is we get a bunch of vasodilation and increased capillary permeability, in this case in the bronchioles. So why would we do that? Well, we know that we have all of our white blood cells, all of our macrophages, basophils, all these different white blood cells, all of our immune function contained in our blood. And if we are trying to fight something off with our immune system, we need to get more blood to the infected area. We get more blood there through vasodilation. It's easier to move blood through a larger vessel, right? Simple fluid dynamics there. Then what we also do down at the infected area is we increase the capillary permeability. Well, why would we do that? Well, it's one thing to get the blood to the site. It's a whole other thing to get the white blood cells out of the blood into the area that we need to kind of have this war with the virus. We get those white blood cells out of the blood by kind of making the capillaries a little bit leaky, I guess is a good word for that. So now we have lots of blood going to leaky capillaries, and as a result, we get fluid shift from the vascular space to the interstitial space. And that's really, really beneficial for the mobilization of immune bodies, but it also brings with it some fluid, and with the fluid we get edema, and with the edema that fluid is going to irritate the bronchioles, and the bronchioles are going to bronchoconstrict. Right? Anytime we irritate the bronchioles with anything, we bronchoconstrict. Now, bronchoconstriction causes difficulty exhaling. And just think about an asthma patient. They're always breathing through pursed lips, right? They're trying to breathe out. It's hard for them to breathe out. So we end up getting difficulty exhaling here. Now, eventually, if this goes untreated, this difficulty exhaling goes into a respiratory failure, and we would call that an expiratory respiratory failure, or an expiratory failure. Now, the other thing that happens with our cellular injury, like we said, is we get that mucus production, and we get a partial airway obstruction. Right? If we fill our bronchioles with stuff, there's less room for air to move. So it's no different than, almost like a choking in some regards, where we're filling the airways with stuff, and therefore air has less of a lumen to travel through. Now, this partial airway obstruction here, all this mucus, is going to cause a difficulty in inhaling and eventually a respiratory failure on the inspiratory side. Main point here is that when we have a severe bronchiolitis caused by an RSV infection, we get this respiratory, inspiratory, and expiratory failure. Hard to breathe in, also hard to breathe out. So what we're going to see here is in the early kind of phases is we get an increase in the respiratory rate. That makes sense. If I'm having trouble breathing, I'm going to need to breathe more in order to kind of meet my my oxygen demands. I see an increase in work of breathing. We'll kind of look at what that looks like in a sec here, but it's things like grunting, it's things like intercostal retractions, it's things like tracheal tugging, that type of stuff, all those accessory muscles. For the medics in the room, we'll see an increase in end tidal CO2. If I can't breathe out as much, right, I get that CO2 trapping, and similar to asthma, I get an increase in my end tidal CO2. I'm going to see bronchoconstriction and wheezing as the bronchioles get angrier and angrier and angrier. They constrict more and more and more. I hear that as wheezing when I listen with my stethoscope. And like we talked about, we get an increase in temperature, right? We get that fever. On the decrease side, late, we're going to see a decrease in respiratory rate as we go from respiratory distress to respiratory failure. And we'll kind of define what those terms are in a sec here. We're going to see a decrease in SpO2, and then a decrease in mental status. And as we mentioned before, a decrease in PO intake, because no one wants to eat when they're sick. And it's really hard to eat when you are focusing all your attention on breathing, right? And a decrease in urinary output caused by that decrease in PO intake. So that kind of ties in with some of our assessment questions for, or at least our little ones of, how many diapers are they going through in a day? More diapers, less diapers, is the urine concentrated, that type of stuff. So we're mentioning respiratory distress and respiratory failure, and we have to understand that respiratory distress and respiratory failure, or I guess work of breathing, is kind of a continuum here, where we go from something that I call happy breathing, which is the kid's just breathing normally, a healthy kid, normal work of breathing, and he's meeting his metabolic demand. And the only point I have to make on happy breathing is that crying here is absolutely okay. Crying does not necessarily indicate that the kid is having trouble breathing. It could, but it doesn't necessarily do that. And in fact, when kids are really focused on their breathing, they probably aren't going to cry. Then we get into respiratory distress, where we have signs and symptoms of increased work of breathing, but they're still able to meet metabolic demand. They're still able to breathe on their own. They're working hard, but they're getting the job done. Eventually, we get into respiratory failure. And the best way to think about respiratory failure is that it is a failure of the respiratory muscles. They're no longer meeting metabolic demand. And these kids are often described as looking tired or looking as if they are failing, because that's exactly what's happening here. So I think about this as like, you know, doing push-ups, right? You start to do push-ups and maybe you're having a little bit of muscle distress, right? Maybe it's a little bit difficult to do some of these push-ups, but you're able to get it done. You're able to complete your set, right? Then when we go into muscle failure, we're maybe like halfway through a set and we physically cannot do another push-up. Our muscles have failed. If we take those push-up muscles and make them respiratory muscles, that is respiratory failure. So we're going to see a decrease in respiratory rate. Patient's tired. Patient is, head bobbing, going to sleep. Really, really, really dangerous stuff here. And then, of course, if we have complete failure, we're in respiratory arrest, and this isn't always a fatal thing here. Now, on this continuum, this is always going to progress to the right if the virus has its way. But if we have our way, we're going to progress to the left here, right? And one important thing to kind of understand here is that in a lot of conditions, RSV included, is that if the patient goes from distress to failure, they're going to end up in arrest unless we do something. And that something could be oxygen support, it could be BBM ventilation, it could be intubation, it could be BiPAP, could be a lot of different things. But we got to do something to stop the progression of this respiratory distress to respiratory failure to respiratory arrest kind of continuum here. So we got a couple of videos here to demonstrate some of the accessory muscles, some of the kind of like the badness that we would kind of think about here. So first one here, not a lot of sound of this one, but if we can look, we can see two things here. We can certainly see subcostal retractions down there at the bottom of his rib cage, and we can see nasal flaring up there at his nostrils. Right, both kind of bad signs. I think someone should probably put the camera down and do something about it. So if we think about like what's actually happening here is we have this nasal flaring, and all nasal flaring is it's an attempt to increase the diameter of the airway to get more air in it. It goes back to what we were saying, bigger airways, more airflow. Right? Simple. So one of the easiest ways that we can increase our intake of oxygen is we do nasal flaring. Now, this is no different than you go out for a run and you start to breathe through your mouth. Why would you breathe through your mouth and not your nose? Bigger opening, easier to get more air in quicker. And we have these substernal and subcostal retractions, right? All of these kind of retractions happening below that rib cage that we can see there. This is caused by the diaphragm contracting harder than usual, which results in larger amounts of negative intrathoracic pressure. And that negative pressure kind of pulls in some of those tissues underneath the rib cage, because we really created a vacuum within the lungs. Now, what this implies, what these retractions imply, is that as long as the guy's like our little cute baby there, his respiratory rate was okay, and his diaphragm is working, and in fact, his diaphragm is working harder than usual. So he's not in respiratory failure yet, but he's heading in that direction. The harder he has to work those muscles, the shorter amount of time we're going to have until they fail. Right? So it's like taking those push-ups, and now we're going to add weight on his back and see how long he has until he fails. Both of these imply an inspiratory failure, right? I want to get more air into the airways, and I want to do that by either opening the airways, making the airways wider, or I want to contract the diaphragm quicker. Next video here, this kid's super cute. There we go. Super cute kid. We're going to watch one more here, then we'll talk about him.
Nah, he don't.
So first video, a cute little kid, we have him grunting, right? He's grunting with every breath. And grunting is caused by a closing of the glottic opening as a means to increase PEEP. So let's just think about that for a sec. If I take a breath in and I grunt on the way out, every time I grunt, I'm stopping air from exiting. I do that by closing the vocal cords at the glottic opening. If I stop my exhalation process, I keep more air in my lungs for longer. If I keep more air in my lungs, more air means more pressure in my lungs. We call that pressure that's now at the end of exhalation, PEEP, positive end expiratory pressure. PEEP is our main determining factor of oxygenation, right? More PEEP means more oxygenation. And this is the basis of what CPAP is, how CPAP works, and a big part of how mechanical ventilators work. So what that means is that if PEEP is our primary means of oxygenation, our body grunts as a means of fixing an oxygenation failure, right? The second video, a little bit of a bigger kid, we could see that he had some of those same kind of subcostal retractions there, but we also heard there was that higher pitched noise. And if we were listening carefully, that was a high pitched noise on inhalation. And that high pitched noise is stridor, right? And that stridor is it's a whistling made of the upper airway. We don't really see this a lot in RSV as much as we would see it in things like croup or epiglottitis, or some sort of upper airway, maybe like an anaphylaxis, something like that, but all upper airway types of things. And that implies an airway failure, right? We have almost like an anatomical failure of the airway due to swelling or partial airway obstruction or something along those lines. Right. So what we had mentioned before is that these RSV kids have the tendency to go apneic. Right. And there was a case in Middletown of a kid who was having, extended apneic periods to the point where he ended up, this is kind of the case that little Bobby is kind of based off of. But the primary call was actually for a cardiac arrest because he had an apneic period to the point where he lost pulses, chest compressions were done, baby kind of woke up, started breathing a little bit better, ended up intubated at the Children's Hospital, a couple of, when the kid eventually landed at the Children's Hospital. But where's the apnea come from, and the science behind it is kind of interesting. There's two theories. There's one complicated and one easy one. We'll do the complicated one first. The complicated one is that we have this thing called the laryngeal chemoreflex, which is stimulated. So what that chemoreflex is it's the thing that prevents you from breathing in debris, right? So we all have probably had the situation where we swallow a little bit of water, but it goes down the wrong pipe and we end up coughing and coughing and coughing and coughing and coughing. That's laryngeal chemoreflex, right? And the whole time that we're coughing out and coughing out and coughing out, we're certainly not breathing in. Now, what we also have back there in our larynx in kids, and the smaller the kid, the more active this is we know that chemoreflex isn't as kind of developed. And when it gets stimulated, it can cause apnea. And this is why sometimes when the little guys are being fed, they'll stop breathing when they're eating. And everyone kind of thinks it's because they choked a little bit, but in reality, it's probably because this chemoreflex has been stimulated. They stop breathing. We stimulate them a little bit. They wake up. They start breathing. All is well with the world. Now, it's thought that in our little kids, this apnea may come from some inflammation, edema, whatever, some of that viral infection stuff stimulating this reflex and therefore causing apneic periods. Now, the other thing that is the theory is the respiratory failure theory, where the little guy's just all tuckered out. And the reality is it's probably a little bit of both. But the moral of the story, the main point here is that these RSV kids, we may need to ventilate them either short-term or long-term, right? There's a good chance that we're going to end up, maybe not a good chance, but there is a chance that these little kids are going to end up needing some sort of BVM ventilation. Now, when we do BVM ventilation, positioning is absolutely everything. And if we look at our little guy here, cute little guy here, and he's laying completely supine, no padding, no anything, we're not going to be able to get any sort of breath into him in this position. We can see that his neck is flexed forward. It looks like he's kind of looking down a little bit. And that's because our little guys like this have these huge occipital lobes, the back of their skull, proportionally to adults. And when they lay flat, their neck is actually slunched, kind of crunched forward a little bit, almost like he's doing a sit-up. And because of that, his airway structures aren't going to be as open as we would like them, and BVM ventilation is going to be sick. So a lot of people think the solution to this is padding behind the head. It's not padding behind the head, because if we look here, this actually just made the whole situation a whole lot worse. So we definitely don't want to pad behind the head. The correct thing to do here is to pad behind the shoulders. And when we do that, we see his neck is nice and straight. We have him in that nice kind of sniffing position. Looks like he's breathing okay there. And that's the position that we want in order to do BVM ventilation. That's our sweet spot. That's our goal here. It's called our sniffing position. It's kind of changing gears here. Who's at risk? We touched on this at the beginning, but those are our big populations on the left of the screen here. Our preemies, premature infants less than 36 weeks gestation, our infants less than 6 months. And our Connecticut data showed that we're at roughly 250 per 100,000 kids under 6 months are hospitalized for RSV. Children less than 2 with heart-lung disease, immunocompromised patients, and any kiddo, or really anyone, but for today, any kid with a neuromuscular disorder. And why are they at risk? Well, it's one of these 3 reasons. So premature infants, they can't fight it off because they don't have an immune system built up yet to fight it off. Their lungs aren't healthy or grown, right? So they're already at a disadvantage. It's already hard for them to breathe. And they have poor muscle tone, right? Muscle tone meaning their diaphragm or their cough reflexes or their intercostals or, any of those kind of respiratory muscles aren't as developed, meaning that they're going to fail quicker. Infants less than 6 months, it's kind of the same situation. Can't fight it off. The immune system hasn't been developed. In that poor muscle tone, they haven't built up that muscle kind of stamina at this point in their lives. Children under 2 with heart-lung disease, lungs aren't healthy or grown, right? We know that they have a pre-existing heart or lung problem, so it's going to take a less of a hit to kind of make their lungs sicker than they already are. Immunocompromised, makes sense, can't fight it off, right? Their immune system isn't as functional as it should be, so they're susceptible to all types of viruses and bacteria, certainly RSV being part of it. And then our neuromuscular disorders, it's all about that muscle tone. And it's muscle tone not just from a respiratory muscle standpoint or from a diaphragm, intercostal muscles, any of that stuff, but also, we said before, like one of the primary kind of defenses we have here is we inhale viruses, we catch it in mucus, we cough it up, we spit it out. Well, if I don't have muscles capable of coughing, all of those kind of trapped viruses remain in the body for longer, worsening the infection. The main point here, the absolute main point here, is that the younger the child is, the greater the risk is. And with this, we have to take into account gestational age. So there's a really, really big difference between a 1-month-old full-term baby and a 1-month-old baby who was 2 months premature. Math says that preemie is actually like negative 1 month old in some regards, right? So we have to take that gestational age into account here. I'm going to throw another poll up here because I need a sip of water. Our next poll is our knowledge check to see kind of what we've learned thus far. So this is a check all that apply situation. Which of the following statements about RSV is true? Check all that apply. Bronchiolitis is inflammation of the bronchioles, which leads to bronchoconstriction and air trapping. Check that one if that's true. Bronchiolitis always results in pneumonia. Check that if that's true. Very young children and children with pre-existing conditions are particularly at risk. Check that if that's true. And then only kids get RSV. Check that if that's true. Do the coffee water double. And while we're at it, just for good measure, I'm going to throw that sign-in link down in the chat for those that joined a little late. All right, let's see. Looks like good results here. Good results. Let me share these up. Yeah, so right on par here, right on par here, where bronchiolitis is inflammation of the bronchioles, absolutely correct. So that first one is true. Second one's actually false. It doesn't always result in pneumonia. Oftentimes there is a coexisting pneumonia, but not necessarily. And the third one, absolutely true. The very young kids, pre-existing problems are particularly at risk for worsening worst cases. Then only kids contract RSV is false, like we talked about. Our older, elderly population are also particularly at risk for this, even though that's not what the basis of today is all about. Great, let me stop sharing that, get rid of the poll, and we'll move forward. So what can we do? What can society as a whole do? First one at the top left here is stop kissing babies. And it was election week, so I couldn't resist putting in pictures of presidents kissing babies. And because I know that the political environment is very, very, very charged, we're going to keep this kind of bipartisan, where we have a Black Democrat kissing a white baby and a white Republican kissing a Black baby. So I think I covered all of the bases, or at least most of the bases there, but we need to stop kissing the babies. Understand that you can spread RSV for 3 to 8 days after exposure. And your symptoms as a healthy adult, assuming we're healthy adults on the call here, your symptoms may be very, very, very minimal. It may just be a little bit of a sore throat, a little bit of a runny nose, but that could be potentially fatal for a kiddo, right? So we need to stop kissing the babies. I don't know, do something else with the babies, but stop kissing the babies, and understand that some people can be contagious for several weeks after exposures here. It all depends on your anatomy, all depends on your physiology. Second point here, sanitize surfaces. RSV can live on surfaces for several hours, right? So if there's a sneeze, a cough, or whatever, and some RSV virus goes out, sitting on the counter, sitting on the stretcher, sitting on the back of the ambulance, whatever, that can be there for several hours and then be inhaled, up to several hours later. So sanitizing surfaces, if we're thinking from an EMS perspective, that's going to be cleaning the ambulance between calls, all the usual stuff that we would kind of expect here. Stay home if you are sick. That makes sense. It's probably not a big deal if you give your coworker RSV, because as adults we have an immune system built to kind of fight this thing off. Might get some cold symptoms, not a big deal, whatever, but that coworker may bring it home to their family, and that's what we want to stop, is that spread, particularly to the kids. And then the oldie but the goodie, probably the best thing to do here is wash your hands, right? RSV can live on your hands for at least 30 minutes and in some instances several hours. So you think about that, you just sneezed into your hand some RSV particles, and now that RSV is going to live on your tissue for potentially several hours. So we can see how that's going to speed up the spread here. So what can we do as EMS here? Assess and reassess is a big thing here. Understand the at-risk population. So again, the younger they are, the more at risk they are. Any kiddo with any sort of pre-existing heart, lung problem, anything along those lines. Understand that kids compensate well, but decompensate quickly, meaning that they are going to be okay until they're not. So they're going to breathe and breathe and breathe and breathe and breathe, and then they just decompensate down to nothing as they cross from that distress to failure point. Ask all of the sick questions. Any fever? How high is the fever? Have they been eating okay, drinking okay? What's their urinary output? All those usual kind of sick questions. Ask about potential exposure. So this could be something as simple as, are they going to daycare? Have they been around anyone sick? Things like that, plus all the usual stuff. So no vital signs. Are they a healthy kids? History, all that stuff is still there. Now, airway and breathing is another thing that we can do here. I would say the biggest thing here is know where that pediatric equipment is in your ambulance or your fire engine, or whatever you're using. Make sure you know where that PD stuff is. We don't use it a lot, and oftentimes it's easy to be like, oh, you know what, I don't really remember where that pediatric BVM is, or those pediatric airways are, or those little bitty suction catheters, or whatever else. So refresh on where that pediatric equipment is so that you can grab it in a hurry. All of our usual oxygen therapy stuff applies here. And if we do need to ventilate these patients, be gentle, 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 gentle. We want to make sure that we're positioning the patient properly. We want to make sure that we are giving them breaths only until we see chest rise, and absolutely no more. And this is going to be a lot less breath than we're probably than we would probably think. We're talking, gentle bag squeezes just until we see chest rise, let them exhale, go from there. Right. Then for our medics in the room, maybe some albuterol, maybe some CPAP, BiPAP, some sort of pressure support there. But the reality is the albuterol probably isn't going to do a whole lot because, as we mentioned before, the bronchoconstriction is caused by that inflammation. And if we don't get rid of the inflammation, the bronchoconstriction is always going to be there. So it's more of a comfort thing that we might get some short-term relief out of it. But RSV in general is certainly not as reactive to albuterol as something like asthma is. But certainly a consideration to give. And then our support thing, right? Our support. Explain what's happening to the parents, the caregivers, brothers, sisters, whoever you have on the call here. It's certainly scary for them. The news outlets don't help with everything that they're putting out. And try to provide that advance notice to the emergency department if you can. Now, the other night, a couple of questions came up here, so we'll address those. The first question was, is known or suspected RSV a kind of an indication for transporting directly to like a CCMC or a Yale Pediatrics? The answer to that question is no. If you're using the diagnosis of RSV as the sole kind of reason for your trip to Hartford or Yale, then no, that's not what we should do. We need to get these kids to a closer facility to get them managed, and then we can arrange for transport kind of afterwards as beds become available. Now, you can think of this from kind of two directions. And the one direction is the kid's not that bad, he can probably take the trip. Well, if he's not that bad, he's probably not going to get admitted for this, right? So don't tie up the pediatric specialty centers with the kids that aren't, super sick. Now, on the other end, we can say, well, what if the kid is super sick? Well, if the kid is super sick, then we don't want to drive him across the state to a specialty center when we have capable hospitals closer. And clearly, this is going to be a little bit different. I know there's a couple of people in here from New Haven today, so that kind of makes sense that that transport destination would kind of change. But if you're using RSV only as your kind of means for transport destination decision, then that's not a thing that should be, right? Hopefully that makes sense. And the second question that came up here was, what about PPE for our responders here? I would say any pediatric patient that you deal with, you should certainly be in a surgical mask. This is more about not getting the kids sick and less about not getting us sick, which is a little bit of a reverse from COVID. So surgical mask, absolutely. Gloves, absolutely. Careful how we're handling those pediatric patients. I know some departments are doing, the N95 or equivalent for all respiratory cases. I think that's absolutely fair, because remember too, like these respiratory cases we think could be RSV, but very well could be COVID as well. So I would say, my official answer for it would be RSV and COVID look a lot similar, look very similar to each other. So I would say COVID precautions with any sort of respiratory thing kind of makes sense to me. All right, so what can the hospital do? The hospital can do really a lot of the same stuff. Supporting oxygenation is a big one. So that's going to be oxygen therapy from non-rebreather, nasal cannula, whatever. Lots and lots and lots of suctioning, right? Because we have lots of mucus production, so lots and lots and lots of suctioning. High flow nasal cannula, HFNC, here's high flow nasal cannula, is something that's becoming very, very, very commonplace. High flow nasal it was actually a thing that's been around and for like the neonatal populations and the really small kids since the 80s. It's not new technology, but it really kind of caught ground in COVID and the adult populations where a lot of people started to become a little bit more familiar with it. And what it is, it's a nasal cannula. It's a specialized nasal cannula that delivers high flows of oxygen. So all that stuff in like EMT classes about how if you deliver more than, I think it's 8 liters per minute or whatever through a nasal cannula, you're gonna like blow the patient's nose off or whatever it is they say. It's simply not true. And by delivering higher flows of oxygen through the nostrils, we get higher flows of oxygen down into the lungs, and we actually create a little bit of PEEP in our little guys. And if we create PEEP, we support oxygenation. And what's nice about that is they're not on a mask and they're not intubated, so they can still do things like eat and take PO meds and drink water and things like like that, versus them being on CPAP or BiPAP, where they're really restricted by the mask, and they can't do a lot of the day-to-day things that we would expect them to do. Then if all else fails, hospitals are going to intubate these kids and put them on mechanical ventilation, and respiratory therapy is going to monitor them and go through ventilation strategies to support their needs. Medical management is another thing. Like we talked about, nebulizers and steroids probably aren't going to do too terribly much. Like we said, the primary problem is that inflammation. Steroids seem like they're a good idea because they're an anti-inflammatory agent, but ultimately, the research says that they probably don't do too terribly much, and the same was true with COVID. You got to really think like the root cause here is the viral infection, and ultimately that's the thing that needs to be treated. Unfortunately, that's the thing that is the most difficult to treat, because viruses are very difficult to manage in comparison to something like a bacterial infection. Because in a bacterial infection, we can give antibiotics, and antibiotics will kill the bacteria, and the problem's solved. But viruses aren't really living, so you can't really kill something in the way that you can kill a bacterium, right? So there are a couple of meds out here. I'm going to butcher the names, but that's okay. The first is paluvizumab. It's a monoclonal antibody, which is really the Pax. It's to RSV what Paxlovid is to COVID, and what it does is it's antibodies. So it gives you some antibodies to start to fight off that virus. And the way that antibodies work is antibodies go in and it binds to the virus and it starts to break that virus down. It starts to break it apart. We can certainly see how that's going to be a beneficial thing. Ribavirin, there we go. Ribavirin is an antiviral medication. It's a really kind of interesting one, because it works similarly to the antibodies, but it works directly onto the viruses to break those viruses apart. Again, it's a similar thing to the palivizumab, but both of them are working to directly break down that virus itself. And there is some advancement in a vaccination for RSV, and there's about maybe a dozen or two different variations of the virus that are in testing here. Pfizer had one to get through their phase 3 trial just last week. So it's expected that their version of the vaccination is going to go to the FDA relatively soon for improvement or for approval. But the way that the vaccinations work, it's kind of interesting, is that they're not so much working on the virus itself, but if we remember, RNA viruses inject RNA in an enzyme, and that enzyme is needed to make that viral RNA into viral DNA. Some of these vaccinations are working on that enzyme rather than on the actual virus itself. So it's working to deactivate that enzyme. And if we can't create that viral DNA, then we can't replicate the virus. So a lot of kind of science going on, a lot of stuff going on with our friends at our big pharma, I guess, companies doing some work with vaccination here. Also in the hospital, what kind of makes sense here is supportive care, right? IV fluids, blood pressure support, nutrition, rest, all the usual suspects that we would expect of anyone admitted to the hospital. So our objectives, we start at the beginning. I always like to start with the objectives and then end with the objectives to make sure that we kind of did what we were supposed to do here. So we said we wanted to understand the basics of virology. So we talked about RNA viruses and DNA viruses and kind of the differences between and mutations and all that stuff. We wanted to look at the epidemiology. So we looked at those graphs. We saw that, in Connecticut, we're about twice the national average as far as hospitalization rates go. And we're way up on our little guys, our under 6 months guys. Pathophys of RSV, we talked about bronchiolitis, we talked about inflammation, we talked about bronchoconstriction and kind of that inspiratory versus expiratory failure, and how RSV gives us a little bit of both, unfortunately. Assessment and management, we looked at those videos of what respiratory distress, respiratory failure looks like, talked about fevers, pulse oximetry, that type of stuff. And then our management being oxygen support up to BVM ventilation and all the techniques for BVM ventilation that we need. And our basic techniques for stopping the spread, right? So stop kissing babies, wash your hands, clean things. Don't go to work if you're sick. So before we wrap up here, we're going to wrap up with the end result of little Bobby. But before we do that, I want to open it up to any questions that we have thus far through the morning here. Feel free to throw them into the chat or unmute yourselves. I think we're small enough today to unmute ourselves. Let's take a sip. All right, hearing none, seeing none, we shall move forth. So if we remember, we last left with little Bobby. He was born in a COVID world. He went through 2 RSV seasons completely unscathed. He gets into this current RSV season and ends up intubated after having some going by 911 ambulance to the children's hospital after some apneic period, some respiratory distress. So what ends up happening with little Bobby up at the children's hospital is he ends up intubated. He ends up on a ventilator for just short of 6 days. He's monitored by respiratory therapy. They go through all their ventilatory strategies. They do all of their stuff that their respiratory therapy teams do. He's eventually weaned off to that high flow nasal cannula. And that's a really, really important thing to understand here is that all a ventilator does in some regards is it takes control of the respiratory drive for one, but it offers relief of the patient since the respiratory muscles have failed, right? It's the same thing that BVM ventilations do. Pressure takes away workload, right? If the pressure is expanding the chest, the respiratory muscles don't have to, and therefore they get a little bit of a timeout. So he had that little bit of a timeout for 6 days or so on the ventilator. Muscles recovered, lungs got a little bit healthier. He got his some meds, some antibiotics, not antibiotics, some meds. He got some fluids, nutrition, that type of stuff. And eventually he was doing well enough breathing on his own that he was able to be extubated, but still required some oxygenation support in the form of high flow nasal cannula for a day or two. And then he gets weaned down to a traditional nasal cannula. And then 11 days after his admission, Bobby's discharged home with no lasting effects of the illness and a body filled with antibodies. And that's an important point here, is that when we get sick with RSV as a kid, we create antibodies to fight off RSV. And now what little Bobby has is he has all of these antibodies that have formed in his body because of his illness this year are going to help him out next year. That's not to say that he's not going to get sick, because remember, this virus is likely going to mutate a bunch of times, but it means that his symptoms probably aren't going to be as bad. So while this year he's intubated and on a ventilator in the children's hospital, next year maybe he's going to get like cold flu type of symptoms. Certainly a better place to be. And in some regards, that's kind of what we're dealing with, or the lack of that is what we're dealing with this year. We have 2 years or so of kids who never developed antibodies that are all getting hit with this thing all at the same time. My hope is that once we get through this year's kind of spike in everything that's going on now, subsequent years are going to start to relax a little bit. With that, make sure that you guys have signed in. I'll put the link in the chat one more time, or scan the QR code on the screen. And if anyone, I'll stay on the call for a little while if anyone wants to discuss anything, or you can always email me. My email address is there on the screen. And I'm going to stop my recording.